It's 4 minutes past 3. So, hello everyone. Warm greetings to all of you from Amman, and many thanks for joining us today. My name is Yorgos Kalps, Regional Representative for the MENA region, and I would like to warmly welcome you all at today's webinar, which focuses on current approaches of using CVA for health outcomes, drawing on examples from the MENA region, but also from other parts of the world. Now, this synthesis report was completed in close collaboration with WHO and other key stakeholders with the support of the German Federal Foreign Office. This study responds to priorities identified by practitioners who in a recent survey highlighted the need to invest more in understanding better how sector-specific cash and voucher assistance can support different humanitarian sectors. Now, as we continue to explore how CVA can be used more effectively to meet or support different programs, we need to acknowledge that CVA does not always offer a panacea or solutions to all challenges, but along with other tools, it has an important role to play. Moreover, the more we learn, the more we can see the many possibilities that exist. We believe that by coming together and sharing experiences, examining the evidence and learning from one another, we will all be more effective and make faster progress. For that reason, I would like to thank all of colleagues from all organizations for their willingness to contribute proactively in this study with their inputs and feedback. And before I hand over to our moderator and my close colleague, Julie, and then to Andret Griekspoor, the senior advisor from WHO, to take us into more detail, I would like to thank our consultants, Anna Horter and Corinne Granger, for the great levels of professionalism they showed to carry out this study successfully. Julie, over to you.
Thank you, Yorgos, and welcome everybody. It's lovely to see new and old faces in the audience. So I'm going to hand over straight to Andret Griekspoor, who's been a close collaborator on the steering committee for this piece of research, along with UNHCR and UNICEF and the Danish Red Cross, the Norwegian Red Cross, and other key stakeholders in the region. So Andret, you're going to set the scene for us in terms of some of the key thinking we need to have in mind to understand this research that's been done. And then Anna and Corinne will give us the presentation. There'll be time for questions and a good discussion. Please use the Q&A box for your questions, not the chat box. And then we'll have a quick poll at the end to try and rank the recommendations that are coming out of this research. And then Yasmin Moore of Cash Cap, who's currently working for WHO on the Cash Task team, she's going to tell us about some next steps that we're hoping to take and about an upcoming workshop. So over to you, Andret, and thank you very much.
Yeah, thanks, Julie. Thanks, everybody. Let me see if this works. Screen one. Go, go, go. Okay, did it do something? Or am I still not?
We can see your screen, and we can see you need to go to the display settings.
Yeah, okay, that doesn't hold, huh? Okay, this better?
Yeah, I think you've done it.
Yes. You think that with an academic degree and 1 year working at home, you managed to run all these things. So what I was planning to do is to put this work in a broader perspective of how, with the Global Health Cluster WHO Cash Task team, we've been working on looking at cash and voucher assistance and how it's applicable in the health sector. I think we made some significant progress since we started working on this. What was it? I think 5-6 years ago. But we also felt that there was still a barrier for our colleagues, clusters, and partners to apply it in the field, to consistently consider cash and voucher options for the health sector within the health sector strategies of HRPs. And so we started shifting from the theory and saying, yes, it is good, it does work, to trying to show more examples of how it is being done and that it can be done, and if so, how it works in practice. But just to put things into perspective, I will share with you a few slides just to frame cash and voucher assistance in broader concepts that we apply for the health sector. Also, I think we should use the cash and voucher assistance as one of the entry points into this humanitarian development nexus. I think a lot of the CVA for the health sector have characteristics that start leaning into financing modalities that we also see for universal health coverage. So, and this collective outcome, if you wish, that all people can use the quality health services when needed without suffering financial hardship, is an outcome that I think we both share from the development as well as from the humanitarian side. And basically, how we approach this work on CVA is that we look at it through the lens of how can we get to this outcome by addressing barriers that there are for either the delivery of services or the access and utilization of it. So particularly the accessibility, affordability, and some elements of effective coverage will be addressed through this work. And one of the principles that we agreed upon with the health cluster already, I think 10, 11 years ago, is that we should provide services for free, that people should not pay when they're ill to a service provider. There's plenty of evidence that there's financial barriers, catastrophic expenditures. So the idea is people should not be charged. Now, the cash and vouchers provide us some options to address these user fees and either reimburse them to the provider or reimburse them to the patients. Now, despite this objective, this commitment that services should be free at the point of delivery, in reality, we see through a lot of household expenditure surveys that are done by cash working groups as well as ourselves, that people still have significant health expenditures. And I think this is where we can do more and better identifying what these barriers are and what the different options are that are at our disposal to do something about it. Now, this one I will just glance over, otherwise I talk too much, but we will share the slides with you afterwards. It's just to say that in this whole broader cash assistance discussion, which is very much based on this market-based approaches, we say that that market mechanisms don't work for the health sector, and in fact, there's a market failure, and there's many reasons why that's the case. One of the things that we look at more closely, again, is this out-of-pocket payment and user fees to address equity and reduce financial barriers in access. Now, the other thing is that we need to be mindful of some of the basic health financing principles when we look at CVA, and that we don't do things in a way that actually undermines basic principles for delivering services and its health financing. And these principles that you see here are basically from the health financing colleagues for UHC. They also work towards reducing user fees. They talk about reduce private funding or out-of-pocket payments, increase use of public funding, either from government, taxation, prepayment, pooling of funds in an insurance fund or health equity funds that then does strategic purchasing, paying for services either to the provider or reimbursing patients through different mechanisms. And I think there's a growing recognition from my colleagues on the financing side that this should be complemented and should be complemented by demand-side financing. And this is a statement that Anna and Corinne will explore more deeply, that when we are talking about a financial transaction, a payment for health, be it on the supply or the demand side, it has to be linked to a particular beneficiary, when they need a specific service from a qualified provider, and it should address the barriers that he or she encounters when accessing that care or incentivizing the use or adherence to treatment. Now, this is just a very short walk through different health financing modalities. And on the top, you see the approaches that are more typical in the UHC health financing modalities. Provision of centrally funded services. The UK is a good example of that. But otherwise, contracting provider to deliver prioritized health services with different provider payment mechanisms, or reimbursing patients, and these can either be done by paying salaries and commodities, paying for outputs, paying for a service delivered, or including a performance component. Then in the middle, you see a couple of hybrid things that have supply and demand side characteristics. Health insurance can reimburse providers, but also patients. It can also pay for transport and other indirect costs. Vouchers have a lot of characteristics of purchasing and contracting, but they also are considered part of demand-side financing mechanisms. Health equity funds, they also have contract with providers. They usually reimburse costs to providers, but they can also provide cash to patients for indirect costs. And then the more classic demand-side financing is cash to patients to reimburse them for cost for services or indirect costs. The conditional cash transfers that we see a lot in for reproductive health or immunization programs to incentivize utilization. And then last, but definitely not least, using part of the multi-purpose cash transfers for remaining health expenditures. Now, this is the last slide, I think, yes. I think there's no longer a discussion whether or not cash and voucher adds value to the health sector. I think there's plenty of evidence, and there's no reason that the evidence that also exists from the development side would not apply to the humanitarian context. But cash and voucher assistance is effective to improve access to and utilization of health services, addressing in particular direct and indirect financial barriers, but also other elements of quality and some other supply side factors. But we do want to convey the message that in situations where there are these financial barriers, that our preferred option is still on the top side of what I showed you earlier, the provider payment mechanisms, and that CVA should be considered complementary to this and not aim to replace the other mechanisms, but it's always a mix of the two. Now, my last comments is that I've been in so many discussions on cash and vouchers, and sometimes people are restricted by saying, yeah, but if you do it like this, then it's not a cash or voucher modality because we don't give money to the beneficiary, or vouchers we reimburse government providers. Now that is not done in the cash community. It's not considered cash when you make a transfer to a government institution. So my point is, don't get caught up in the definitions of what something means in one group and something else in another group. And don't let the definition, a narrow definition of CVA, prevent you from doing what is the right thing to do to finance the health sector or to reduce financial barriers from a patient people perspective when they're in need in healthcare. And but the other side, the story is that given that there are always financial barriers and that there's a certain reluctance of our colleagues in the field to say, yeah, but cash and voucher, that's not for the health sector, it's for others. We have seen that there's a lot of benefit from CVA for health. So we do want to say explore all options, including CVA, and do so more consistently. Now, what I think is great of the study that we done together with KELP and others is that we're taking this 2 or 3 steps forward and documenting experiences and how things work in the field. I think to also reduce barriers of our partners to actually not only consider it, but also implement it. I think it's, for many of them, it's new, and it's a certain, okay, it's new, so I don't know how to do it, so I won't do it. And I really believe that this kind of study, and the report is great, really helps our cluster coordinators and partners in the field to, to overcome that small barrier of what is unknown is not done. So I'll stop talking and be very happy with great pleasure to hand back to Julie and let Anna and Corinne explain their findings. Thank you.
Thank you very much, Andre. So over to you, Anna and Corinne.
Thank you. Just going to. Right, I hope everyone can see the slides now. Hello, thank you very much to everybody for coming today, and thank you particularly to Julie and all her colleagues at CALP and to Andre at WHO for contracting us to do this work and for making this such a sort of interesting and enjoyable experience. So Anna and I are going to divide up some slides and give you a snapshot of the findings from our study in the MENA region. So this, just very quickly, is the structure of the presentation. We're going to go very briefly through some introductions and definitions. Anna is then going to talk about the conceptual framework that we used, which is based on barriers to health services. And she's also going to explain the different CVA modalities for health. So in fact, building on what Andre was just saying, talking about the different kinds of modalities that we found both in the MENA region and beyond. Then we're going to give you really a very summarized version of the findings from the study, but those are all included in much greater detail in our report, and finish with some conclusions and recommendations. And then we are going to ask everybody to have a look at the recommendations, which are very broad at the moment, and to select those which they feel are most urgent in terms of next steps. So this is just a snapshot of the methodology. Really the first quarter and slightly beyond this year. The countries were defined by the funding for CALP, which was in tiers 1 and 2, which again, I think, as Jorga said, is to do with the German organization that funded CALP. So we looked at 7 countries and Egypt across the MENA region. And we also looked at a number of other humanitarian contexts where there were particularly interesting examples of CVA for health, because we felt that those could offer particularly interesting, certainly examples, and in some cases lessons. The method was very simple. We reviewed nearly all operational and program documentation. We didn't go back to the literature and the evidence because we felt that the case, as Andre said, was really there, the CVA for health. So we really focused on how things work on the ground, and we complemented that by a large number of key informant interviews. And I've noticed that lots of the people that we spoke to and who were so generous with their time are here today. So thank you very much for all your inputs. So going back to the question that Andre talked about, definitions, we did look originally at the definitions of CVA for health, and we found them slightly limiting. So we went back and basically asked 3 questions to try and define what kind of CVA modality we should look at. And bearing in mind that Anna and I both come largely from a development context and from the health sector, we were already very familiar with approaches such as vouchers and health equity funds, which didn't always seem to fit easily within a definition of CVA for health. So the questions we asked were, does the CVA approach address barriers which are constraining the use of health services for a specific group? And that means people of concerns in this case. Are the benefits tied to the beneficiary, i.e. are they a per beneficiary benefit? And can they be seen to be act predominantly on the demand side, i.e. if the person is not accessing a service, there is no funds change hands. And then is the identification of the beneficiary or target group linked to their actual health needs? So we found those 3 questions very useful for placing the approaches that we're going to talk about now into this group. We then, since we've done the study, we moved on to discussing with WHO, Andre and Yasmin and other colleagues about a definition. And this is very much a work in progress. This is a definition that we've come up with, and we'd very much like you to raise questions about this during the Q&A section. And it's something that we're still going backwards and forwards on a little bit. So I'll just read it. CVA within the health sector is linked to a particular beneficiary or beneficiaries in need of specific healthcare by a qualified provider, and which addresses the barriers which they, meaning the beneficiaries, encounter when accessing that care, while incentivizing use of the services and adherence to treatment. So that was our sort of working definition. I think Andre's gone over a lot of this, so I won't dwell on this. It's to do why use CVA for health, to do with market failures in healthcare, and some of the differences which we'll actually come to later between approaches for dealing with multi-purpose cash and for access to healthcare. So I'll move on with that. This is an absolute top-line snapshot of what we looked at. So we identified a total of 26 different interventions. Some of them are actual programs, and some of those are activities within a broader program. 13 are distinct interventions in the MENA region. And then I mentioned in these other countries, we selected 7. And we've included in the report a pipeline, and this is where there was quite a defined concept already in the pipeline, which either needs developing or is lacking funding, which gave us a total of 26 interventions. There was a really huge range of modalities. So while Anna is going to go through the main modality types, I just want to emphasize here that many programs use quite a combination of 2 and sometimes 3 different modalities. And I think the shortest intervention we looked at was 45 days, and the longest, for instance, the Yemen voucher program has been going for many years. So there really was a very large variation in activity. So I'm going to hand over to Anna now to explain the conceptual framework that we used. Go ahead, Anna.
Okay. Here, this is the Tanahashi framework. At the bottom, you see the people of concern, the population of concern. That's the target population. That is the group you want to come to visit the health facilities. Then the next arrow is concerning the availability. That means the number of health facilities which are available, opening hours. So if a person of concern is living far away from a health facility, he or she will obviously not visit the health facility so easily unless she has money to pay for the transport. Then the next one concerns barriers related to accessibility, which is mostly financial. Then you have the acceptability, when people are coming into a health facility and they are treated very badly, they will not come back to visit again. And then the contact coverage, which is actually how many people are actually making use of the service. And then on the top, that's effective coverage, in the fact that if the treatment is not of quality, then of course it is not effective. So this is in order to present some of the barriers people can encounter when they want to visit facilities. Let's go to the next one. Okay. So then here we present the different modalities. So in the left column, you see the costs, which are related to accessing health care, such as cost of transport, accommodation, food, other direct costs, and of course user fees at primary health care or at secondary and tertiary care. But also there might be costs related to medicines, tests, and so on. So each of these blocks, we have filled the second column where you can see the potential modality, like transport cost could be included in MPC or be an MPC top-up, or cash for transport given in advance. There's also a possibility to use conditional cash transfers or vouchers. And for food, the same. But this is, as these are small costs, you usually will just put them into the MPC. And then for user fees, you see that there's a whole list of modalities I will explain in the next slides. And in the third column, you will see the barriers which are addressed, the Tanahashi barriers, which are addressed by by the type of modalities. And as you can see, cash in generally only addresses contact and accessibility coverage, while the conditional cash transfer addresses more. Let's go to the next slide. So unconditional cash transfers. Okay, it looks at the diagram. So at the top, you see the government, the donor funding, which will give money to the implementing agency, often an NGO. And this may or may not contract a financial service provider who then can provide the money to the beneficiaries. This can be, there are two types of unconditional cash transfers, which one is multi-use cash targeted at persons with specific health needs, in a sense, to ensure full recovery after major surgery. Cash facilitates rest, transport for follow-up care, etc. And then the second type, which is cash for specific health services, such as obstetric care of life-saving treatment. Next slide. So an example comes from Northeast Syria for multi-use cash. It is a pilot which is implemented by Humanity and Inclusion and Mercy Corps. The cash is given to persons in need of rehabilitation services in order to pay for costs they have when they want to access rehabilitation care, like transport and so on. This helps people to complete the care they need and to take the required rest, and it can prevent permanent or more disability. The multi-cash may be used for costs such as food or debt repayment. So it is not conditional on the use only for healthcare, but also for other things. But it makes sure that the person of concern can access the rehabilitation care. Then the second example is of cash in advance for specific health needs. The project I want to present is in Iraq. It's named EMCA, and it's a good example of cash which is provided in advance. Even though persons of concern in Iraq have free access to public health services, there can be costs. This is because some treatments, interventions are not available in the public system, but they can be obtained in semi-private or private facilities at a certain fee. Now, in case of need for a life-saving treatment, for example, blood transfusion, appendectomy, the project covers the fees of these health facilities. There are standard operating procedures developed which ensure good referral systems and to health facilities with sufficient quality of care. Next slide. So the second modality I'm going to discuss is conditional cash transfers. So here you see in the diagram again, the government is funding the implementing agency who then may or may not contract a financial service provider to establish a payment system. And then money is given to beneficiaries only after they have done a certain action. So it's often linked with services that are provided for free. And it incentivizes positive behavior change, antenatal care visits, and immunization, for example. The beneficiary needs to pay upfront, which can be challenging for poor. The CCTs are relatively simple to set up and can be combined with existing systems for MPC. That is, CCTs in humanitarian context are relatively easy because there are always already quite a number of monitoring systems in place. So it makes it slightly easier to monitor if the clients have indeed accessed the services. Next one. An example of conditional cash transfers for Syrian refugees with diabetes in Jordan. So in 2014, the government changed some policies and it increased the cost of user fees for healthcare for refugees in Jordan. And this was shown to result in lower use of diabetes care. So Research for Health in Humanitarian Crisis, together with MENA, implemented a pilot study in 2019 and 20. And the study looked at if conditional cash transfers are able to motivate refugees to access diabetes care. And 3 groups were formed: education alone, conditional cash transfers with education, and MPC alone. And the results show that a conditional cash transfer with education together improved the use of diabetes care and adherence to medicine. So diabetes patients were actually able to fulfill all the treatment. The MPC alone was found to be insufficient to improve chronic disease outcomes. Next slide. This is the last modality I am going to show, that is vouchers, value vouchers, and health equity funds. So again, at the diagram, you see the government, the donor, who is giving funding, in this case to a management agency, which still can be an NGO, but can also be government agency. This agency gives subsidies in the form of a voucher or health equity cards to a certain group of beneficiaries. And when these beneficiaries visit the health facilities, they bring the voucher or the health equity card, which is often a poor card, to the health facility. It's an entitlement that they are entitled to receive the services for free or at a very low cost. And in exchange, the health facility gives them services, medicines, or other goods. And in this case, the health provider then submits claims normally every month, might be every 2 weeks or every 6 weeks, to the management agency in order to be paid for the services or the goods which were delivered to the beneficiaries. The interesting thing is that the agency also makes sure that the health facilities are of good quality, that they follow the protocols as they should do, and that they are ready to serve the clients. So this type of modality also strengthened the health facilities produce good quality. Vouchers can be used for specific small type of services like maternal care, but you can also have a large package of primary healthcare services. You can also have vouchers for goods, for medicines or bed nets. And there are also vouchers which have been used for transport. So you give them a voucher and with that they can pay the transporter to bring them to the health facility. The value voucher, it is a form of voucher, but in general it has a larger package and the value is capped. So it's like, okay, up to a certain, let's say $100, you can buy services. And if you go over that, it's not valued anymore. It's not be paid. You have to pay yourself. Then the health equity funds are basically like a large voucher, but the targeting is slightly different. It targets households mostly, and it's more general because the package is mostly a primary health package and it includes often essential health care at secondary and tertiary care. Next slide, please. So this is just a few examples. This is vouchers for safe motherhood and family planning in Yemen. The vouchers were set up in order to address the high maternal mortality due to costs, but also low awareness of the risk of maternity. It was developed before the onset of the conflict and it continued with some interruptions, mainly due to delays of authorization by the Houthi authorities. Nevertheless, the authorities consider the vouchers are very useful because they bring the money where the services are actually provided. And currently it is planned to expand to 6 governorates targeting internally displaced persons, host population and poor population groups. Next slide, please. This is an example of vouchers for drugs and consumables in Ukraine. These drugs are free in the public health facilities, but often the supplies are not available. So people are sent to private clinics, private pharmacies. So the NGO decided to develop vouchers for people so they could buy these drugs and consumables at private pharmacies. It has different packages, medicines for pregnant women, for lactating women, and for children below 5. And also for kids for normal delivery or for a cesarean section, and surgery kits, trauma kits for adults, but also for children. The maximum costs were capped, but that they were increased when needed. The scheme has been active since 2015, and it has been quite successful. Next one. This is an example, nice example from vouchers, value vouchers used in Chad. The data in Chad, the data showed that 15% of HIV patients in the population of concern did not complete their treatment due to costs. They could not pay for the transport nor for the medicines, some of the medicines which were not free in the health facilities. So in Wallet 1, it's a dual wallet, it's called dual wallet. In Wallet 1, there's a cash for transport, and the cash is obtained from Hawala agents which are available when arriving at the health center. The cash is then paid for the transport to the health facility and back home. And the second wallet has a value-based voucher to pay for services or not free at the health facility. Some medicines are not free, tests and consultations. So the patients now can pay with that value-based voucher for any of these services up to a certain value. It's capped. That was a 1-year pilot which worked well, and the plans are to continue and scale if funding is available. Next slide. Last one is an example of a health equity fund in Lebanon. In 2016, the Ministry of Health requested support for the Ministry of Health network of health clinics, and Relief International decided to support 8 primary health care facilities. Instead of providing salaries and supplies, they decided that they would pay the health facilities for the services on a case-by-case basis, and for everybody who was living in the catchment area of these health facilities. Relief decided to choose this modality as they felt that it was better to pay for performance than just only providing the supplies, and that would give them better results. When necessary, Relief also supports the facility with supplies and staff to ensure the quality of care. Next one is for Corinne.
So I'm just going to talk very quickly through some of the findings. This is really highly summarized, but the report will be available shortly, and those findings are all explained in more detail. So we've just divided findings briefly into cash and vouchers as 2 main modalities. I mean, there aren't huge surprises here. We found that mostly cash is used for small items of expenditure and for indirect costs. At least half the countries in the study had at least one program that used cash for small indirect costs, but often as a wider package of other support. There's a few countries here in the brackets. And also a spreadsheet with quite a lot of detail on all the examples that we looked at will be available. I think Yasmin will talk about that later, but it will be made available alongside our report. But cash is also used to pay for services at secondary and tertiary levels, more expensive services, and also to incentivize adherence to treatment regimes and protocols. So particularly for things, as Anna mentioned already, like treatment of, say, diabetes or refugee for rehabilitation. I think I said before that we found no 2 interventions were the same, really. which makes them sort of slightly harder to categorize. Many programs used different, one or more, or different approaches, which we've called here hybrid. Cash was mostly provided before the health service. I think, as Anna mentioned, this is because of the difficulty often in accessing cash, sometimes before and after, in order to try and incentivize people to use a certain specific service, and sometimes just after the event. And there was one example where it was paid in installments. We've used the term multi-use cash in the report because where the cash is unconditional, this was sometimes in the form of an MPC top-up where the MPC was already there, but also, and that could either be regular MPC top-ups, which work if the costs are predictable and low and regular. So something like an antenatal appointment or a child vaccination or an NCD prescription. We also saw an example in Iran, which wasn't one of the main study countries, where they use much higher MPC top-ups, but still using the MPC systems. But then there are also examples where the cash is unconditional, but it's not linked necessarily to the MPC. And in these cases, it seemed that targeting was difficult, locating and finding those individuals in households with high-cost health needs and assessing them, which obviously requires a case management approach. So this seemed to be, well, and is logistically more complex. With cash, other activities are needed to, particularly when the cash is being paid before the services, to link people to the health services that you want them to visit. And this, I think, in order for the concern that people often have, particularly the health sector, that using cash enables people to visit unqualified providers and therefore does harm. Just looking quickly at what we found in vouchers, I think most of these points have already been covered, actually. We found quite a number of instances of vouchers. These countries here, Yemen obviously is the main example, with a couple of voucher programs in the MENA region, but we also found a lot of voucher programs in humanitarian settings in other countries, and some of them not listed here, such as in Ecuador and Colombia. And then we looked in detail at the examples in Burkina Faso, Chad, and Ukraine. They are more suited to protracted emergency situations because they take longer to set up and they're more complex to manage. But balanced against this, they have a stronger impact on health-seeking behaviour and also on the behaviour of the providers. It is worth saying that they're better suited to higher value services, because we've seen in the development context, you see transport vouchers, but the costs, the management overheads of setting up and managing a voucher program make them less feasible really for low-cost services such as transport. But you can add transport or vouchers for food or whatever it is you want to cover in terms of costs if you've got a voucher program set up already. This just goes back to something that Andre said to begin with, which is that over time, and actually this learning comes from a development context, and particularly from a program in Kenya, which went on for many years, funded by the German government. And work there has showed very clearly that the voucher program brought in the skills and expertise needed for strategic purchasing and for, in fact, the introduction of health insurance, social health insurance, because it introduced mechanisms such as targeting, contracting of health facilities, and this enabled them to leverage the capacity not only of the public sector, but of private and NGO facilities, and then the other types of mechanism you need for a voucher program that are also key to insurance. We looked at coordination between the cash and health sectors. And I think this is an area where more research is needed. We talked to people through the KIIs, but we didn't find much that was really written down about this. And this table, I'm not going to go through it, but it just is a sort of snapshot of some of the differences in perspective between the humanitarian cash actors and the health actors. And I think we feel that although coordination now is improving and people have moved beyond this, this is at the basis perhaps of some of the issues, the misunderstandings between the two sectors. I think we found during the KIIs that there was widespread agreement on the need for strengthened coordination. I think our view, and bearing in mind we're not cash experts, so this will be interesting to discuss in the Q&A. So I must finish quickly, actually. Is that while global mechanisms are there, like CALP and like webinars like this, the mechanisms at the country level are weaker for coordination, and that we saw some instances of good coordination, and they tended to be where TA, technical assistance, had been provided, either regionally and in some cases as well as nationally, through cash cap, in fact. Chad is a good example. And where that technical assistance had been provided to both cash and health clusters, the coordination was much better and people worked much more in tandem with each other. So a few of the conclusions and recommendations. I think this is obvious, and I've said it before, it's really taking off. There's a growing number of examples. It really is too early to identify best or probably even good practices. We got asked quite a lot, so which kind of CVA for health is best for which type of humanitarian situation? And the really key point to make here is that it's all dependent on context. So it's about doing the assessment early on, it's the health system characteristics, what are the health financing policies and strategies, and really what are the barriers which are different in every context. And to remember that those characteristics of the health system change over time, so the same modality will need to evolve or change. I'm not going to go through this slide actually, because I think let's keep more time for questions. This is really just about the different modalities or the different respective advantages and disadvantages between cash and vouchers. These slides will be made available, and this is also explored in our report. Something that we really wanted to emphasize, and which we've discussed with WHO, with Andre, is that really what Andre was saying to begin with, that CVA for health adds value to the supply side health interventions. So it's never meant to replace any of the supply side work that goes on, but it does add value, and it does this through directing people to referral services and strengthening existing referral systems, sometimes by using conditionality, which directs people to specific services. Mainly, it's about using sort of quite intensive inputs to health promotion, IEC, behavior change, this sort of thing, which link people to the health service. So while the concern is often if you give people unconditional money before the service, they won't use it to access the service, or they may use it to access a provider who may not be of the required quality. I think in every example that we looked at, except one very small example, this was not the case, and people were accessing the services that they were directed to. And this is because the CVA for health, should never happen in a vacuum. It goes along with health promotion activities. And also verification and monitoring systems are important to make sure, particularly with things like reimbursing facilities and health equity funds, that facilities are not charging for services that were not accessed. So these are very broad recommendations. And I think Hazar at CALP is going to take over here. There are a lot more detail on these recommendations in the report, but they're very much initial recommendations from our findings, and we would like your inputs to these. So we're going to ask people to select those which are most important for their next steps. And they're divided, as you can see, through in fact, sorry, I've just seen that the poll is up. I was looking at the wrong screen. So I will stop speaking and let Hazar continue. Over to you, Hazar.
Thank you. So you can see on the screen we have 3 questions. I will just give you 2 to 3 minutes to pick one option for each question. Thank you.
Might just be worth mentioning that you have to scroll up and down to see all of the choices.
Okay, if you haven't voted, please vote now. I'd say you've got another 35 seconds.
Thanks, everyone. I think I will end the poll now.
Thank you. Can you leave it on the screen so we can see the results?
Yes, sure.
Thank you. So, in terms of technical assistance, training, orientation, the key action is seen to be to provide on-site, country-level, hands-on training in using cash and voucher assistance for health. In terms of funding recommendations, it's about providing orientation to donors on successful use of cash and voucher assistance for health outcomes. So it's about setting up that primary incentive to do cash and voucher assistance for health. And in terms of coordination, well, it's a bit of a familiar story there because it's developed more effective coordination platforms at country level. But I think the fact that this is particularly focused on CVA and health means that it's a bit of a new direction in some contexts. So thank you very much, and we can keep these poll results in mind as we move into the question and answer session. So thank you. If you could stop sharing the results, please, Cesar. And participants, panelists, if you could put your screens on, please. And I will start. There we go. So thank you very much for the scene setting and for the presentation. We have some questions. We also have a couple of questions in the chat box, but if possible, put your questions in the Q&A box, please, everybody. So the first question is from Torben Broom. There seems to be increasing evidence that using only MPC for access to healthcare is not working well. Is it timely to start making that statement? Now, there was some discussion in the chat box, but because it gets to the heart of the matter, I'm going to throw it back out to the panelists to just come in quickly and give us their key thinking on that question. did we ever use MPC solely for access to healthcare, or has that just been a default when we didn't have more money to do things better? What are your thoughts? Andre, I know you're dying to come in on this one. Although I will cut you off after 5 minutes if you come in.
Sorry, I was just typing away at a reply on the chat. If you can repeat the question, I'm happy to say something short.
Oh, now I'm muted. It's your friend Torben's question about, should we stop, we now have evidence that you can't just use MPC for access to healthcare. And maybe we never did, but just a couple of thoughts on that.
Yeah, this remains a mixed blessing. An argument. So if there is increasing evidence that when people use their MPC to access a service from an unqualified provider with a high risk of getting a service from a health worker that has no qualifications, or buying drugs from a drug outlet on the market that you have no idea how it was stored and where it came from, we should obviously not support that kind of practice. But the other thing is that from these surveys, you hear that people are better able to meet health needs when they have an MPC versus those that don't get an MPC. Now, then a tough question is it better that people do have money and that they do seek a health service versus not having money and then not seeking any health service at all? But yeah, you're caught between a rock and a hard place. I definitely don't want to promote and give incentives for people to seek harmful healthcare, and particularly in situations where there are qualified providers, particularly when they're supported by humanitarian partners and the services are heavily subsidized, then why don't they go there? And what can we do to change that practice? And obviously only focusing on giving more MPC so that they can use more services and are happy with it is not the right way to go. These are tough questions. We have to accept that people make use of MPC to pay for health, whether I like it or not. That's what they do. If they spend it in the wrong place for the wrong reasons and get the wrong products and services, we have to step in and do something about that. We only know that when we ask the right questions. And I think, therefore, these PDMs, they should ask more in-depth questions for what people did with their health expenditures, where they spend it and what and what for, which I think in our case is much more important than for buying tomatoes, rice, or vegetables. So unless we have that information, we cannot step in, we can't take action. No easy solution.
Sorry, I have to come off screen because I can tell that my internet is slowing down. I hope you can see me, you can hear me properly. So let's move on to the next question that I've got here, which points out that in humanitarian settings, such as acute but often protracted crises, the quality of health facilities is one important limitation. In that case, is there any benefit in hybrid approaches where CVA is offered in combination with some form of support to the selected health facilities, aiming at improving the quality of services? That could be capacity building on specific services linked to the CVA services covered, as well as donation of kits, small rehabilitation of the facility. So I'll stop at the end of that question, although there's a second part. And Corinne and Anna, what do you think about these hybrid approaches? Are they good? Do they work? Can you think of examples?
They are very, very advisable. It's for sure that even in development context, we often use, for example, in many voucher schemes I've been working with, in the end we said, okay, we need some supply side support, for example, learning how to do a certain technique like abortion care, or learning how to work with adolescents. And then you use also the CVA, the demand side type of thing, in motivating people to come to the health services, which are strengthened through the supply side as well as through the fact that the people who are actually needing this service are now coming to the facilities. So it's a sort of double motivating, because you give the supplies and then immediately the patients come in who need these supplies. So that makes it a very strong response for health facilities. Like in Yemen, they often use, if they get supplies, they're very, it would be even more happy, but because now they use much of the voucher income in order to address shortages in supplies, for example. So yes.
Thank you. I think that's a very comprehensive response. I'll go to a question from another member of the audience. So from Lucas Sangali, we have, are there best practices of cash for health activities in countries where a specific service, like secondary or tertiary healthcare, is non-existent at public level, which means that the patient would only be able to access it through private clinics? Are there any recommendations in terms of CVA modalities? I think one example would be victims of explosives who need meds and rehabilitation. Corinne, Andre, Anna, I'm happy for any of you to answer, but let's see your faces, panelists. Let's make it more interesting.
The example we presented was from Iraq, where they had to set up a system, and UNHCR has set up a whole referral system for people who need care in private or semi-private sector, and which is quite high costs in the secondary and tertiary care. So that is a CVA, whereby you pay cash to the patients before they even go to the services, but based on a whole set of standard operating procedures, referral to the agency, who's then looking at eligibility of the client, of the patients, and if it is worth the effort, or if it is it can be positive outcomes, and then people get the payment in order to be able to pay the facilities. And sometimes when people have already gone to the private facilities before they even could receive the payments, then the payments are done directly to the facility themselves. But it's a good way, this modality of cash for specific healthcare costs, life-saving healthcare costs. And we have several examples in the report of it, as well as in the Excel sheet described a bit more in detail.
Thank you. That's good. Does anybody else want to jump in before I go to the next question? Then I'm going to go to the next question.
Trying to answer the questions on the chat. I've been typing.
Don't answer too many of them, because I want us to discuss them here. So the next question I was going to draw your attention to was, what are the main challenges when you're giving patients, I think, recipients, CVA, and they're going to buy drugs or kits from private pharmacies? What are the main, what are your sort of things to keep in mind when doing that?
Well, one of the most important things is that it should be private facilities, which you can, where the quality is assured of the medicines. Like in Ukraine, they used vouchers for medicines, but these were quality assured pharmacies. So that was the supply side investment, which was done in order to make sure that the vouchers were exchanged for quality products.
Okay. Any other thoughts about how we sort of build up the quality of whatever the patient is going to buy? I mean, I've been quite impressed. I mean, as a sort of cash and voucher person, I've got very used to thinking that cash can do anything. And over the last few months, understanding the use of CVA to achieve the outcomes you want in the health sector, I've realized that actually vouchers have got a lot to offer for the reasons you described in the webinar. But that's been a bit of a new thing for me. So we've had quite a few. Anybody jump in there? So I think I might take us back to some of the questions in the chat. And there's been quite a lot there about this whole business of why just giving people cash. Can you do it? Do people go and misspend money? Are they Are they taken advantage of by medical practitioners who are unscrupulous? Can we just maybe dive into some of the challenges that you've seen, you know, real life examples of where people have had, maybe not too real life, but examples of where health-seeking behavior by a would-be patient, you know, is very unsuccessful when they're not getting access to quality healthcare or quality provision?
Are you expecting it from us, from the development sector, or from the humanitarian context?
I think from either. I mean, you know, Andre perhaps, or Corinne.
In my practice, in developing countries, I've seen a lot of misuse, especially overtreatment. People being requested to buy or to use medicines or undergoing treatments which are clearly providing or making more benefit, which are maximizing the benefit for the provider instead of for the client, and even harming the clients, like cesarean sections, which are not necessary at all, or taking surgery which is not needed. Knee surgery in Holland, we even see that people sometimes undergo knee surgery which is absolutely not needed. They think that probably a quarter is not needed. Things like that. Yes, it's happening everywhere. So you really need to quality assure people, because patients cannot know all the details of the technical protocols. What they can see is that a doctor is nice and friendly, and they say, oh, that quality is good. But that nice and friendly doctor may not use the right protocols. So it's a patient cannot on herself or himself decide what is good or bad for him or her.
Maybe to add what Anna is saying, there's an interesting debate in the chat on whether or not people go to quacks and buy drugs in the market based on what they can pay. I think we lost a bit the tradition of doing more systematically health-seeking behavior studies and trying to understand what people do when they get ill. I do remember from the time that when we were doing this, and also I didn't hear anything to contradict this, that people do have a tendency of first seeing either traditional medicine or doing their own traditional medicine, then seeking healthcare very nearby, often the market, and self-medicate and buy drugs from drug outlets. And when they go to a public facility, they've often already done one or two things themselves before they get to a public facility that is quality regulated by government or supported by a humanitarian partner. Now, the extent to which MPC is thus, if you wish, misused for the wrong reasons and buying the wrong services and not standard, not quality assured drugs, I don't have the evidence. So please help us get our hands on that evidence, collect better information. The other side, when you start reimbursing services, there's all the story that Anna is saying. When we spread the word that when people go for a C-section to a hospital, that their C-section is being paid for by a humanitarian partner, you do see C-section rates going up. If providers get the impression that the drugs are being reimbursed that they prescribe and they take a certain cut of it, or they have a deal with a pharmacy, they may overprescribe. So you do need to have very, very
detailed
protocols against quality standards of treatment protocols and pricing of what they can charge. So both is possible. Even for qualified providers, they can play the system if you put incentives in place to reimburse costs. But there's definitely a high risk that people don't immediately seek a qualified provider when they have a health problem. Do I have exact numbers on it? No. Would I like to have it? Yes, because then we can have a more informed discussion on the use and risk of MPC versus health sector specific CVA. But even for the health sector specific CVA that have good characteristics, there are risks that need to be managed, anticipated, and dealt with.
Thank you very much. So we have a question. I'm going to skip the question on training until the end because we'll have some information, a little bit of information on that. But there's a question which relates to this whole debate. How can we ensure that within the framework of multi-purpose cash, there is a specific quality framework for health services? It's a dangerous territory and we rarely collect enough data about health facilities that beneficiaries access. Now, in the presentation, you've described you've touched on some examples of how this has been done. And I imagine, again, it's quite a lot about context, that if you're in a fairly settled long-term crisis, then you have more ease, more access. But can you just maybe, Corinne or Anna, talk a little bit about some of the key things to do when you're trying to make sure there's a quality framework for those organisations that are providing the healthcare?
I think that's an interesting question. I would only add that, is it the right question to ask? Because does that not go against the whole ethos of MPC, which is about respecting the dignity of the individual, providing them with a minimum basket, to meet the needs that they have on the ground? So do we need a quality framework within MPC, or do we need to be looking at what additional CVA for health can do, either building on MPC where the MPC system is there or not? And that cash can be in all sorts of different ways as presented in the presentation. But I don't know, Andre might like to respond, but I wouldn't have thought a quality framework for health services within MPC was necessarily the right way to go.
Yeah, I can only fully support that. I think there's an acceptance and a recognition that people use MPC to pay for health services, whether I like that or not. Now, if they buy paracetamol, I don't care. But if they buy antibiotic because they have a child with severe acute respiratory tract infection, and I don't know if they buy a quality drug, then I do have a problem. But the solution is not by adding restrictions in MPC. That the moment that you start doing that, you talk about sector-specific cash and voucher modalities, or better making contracts with providers that they provide the services for free to your target population. So the solution for ensuring access to quality health care is primarily in the health sector itself, and finding the right modalities that have proven to be effective in all settings. In the UK and the Netherlands, you don't solve the healthcare problem by giving people a social cash transfer. There's always a mix of social cash transfer on one side and another parallel modality that provides access to quality health services, whether that's the National Health Service as in the UK, or obligatory national social health insurance in the Netherlands. That should be the solution. That multi-purpose cash is there for its own reason. It has social protection characteristics. It's all the great characteristics of choice, self-determination, dignity, making your own choices. But that logic does not apply to the health sector. That health sector protection for financial protection for healthcare has a different logic and should be seen parallel and complementary to the cash program.
That's great. That's really sums it up. So we can't ask MPC to do too much because of the nature of health needs, the way these vary from place to place, because we can't create any sort of quality control over suppliers. We need to recognize that people will use any resources they have, including MPC, to try and deal with health challenges. But your MPC is simply not going to be enough once you're past buying paracetamol or something for an upset tummy. So I think that, and then the work that's been done today and that we'll soon share in the upcoming report, and the report has an Excel spreadsheet which you can also access, where you can see much greater detail on the various projects that Anna and Corinne surveyed. But the report itself basically is a much longer version of the excellent summary you saw in the PowerPoint today. Now we have a few minutes left, and I want to say thank you again to the consultants and to our amazing steering group. And now I want to hand over quickly to Yasmin, who is working for Cash Cup but is attached to WHO, and like me, she's been on a real learning journey around, how cash and health can be used well, can go together. And she's going to tell you about some next steps that we're hoping to take as CALP and some work that's happening next week. So over to you, Yasmin.
Thank you so much, Julie. So Holly actually already mentioned the workshop that we're doing next week. So it's a workshop that we hope will include both health and cash colleagues from the East Africa regional working group that is led by CALP. And the idea is to take stock basically of the CVA and health interventions that exist within that region, and discuss some of the best practices and come up with an action plan for the region to help improve some of the coordination in some of the work around CVA and health. So that's hopefully happening next week. If anyone has any questions, you can email me or Sahara. I think her email was already written down by Holly in the chat box. The other thing that's also coming up, which we're pretty excited about, although it hasn't really been nailed down yet, is working with CALP on a web series around CVA and health. If many of you, I think many of you participated in the MEB series that was done, I think last September. And so it's several sessions around the minimum expenditure basket. So the idea is to do something similar around CVA and health. So more detailed sessions on the design of the different cash and health programs, how to include health within the minimum expenditure basket, some different response options, some different hybrid models. So it should be really interesting, and hopefully we can figure out the dates for that soon, and then we can share with you all. Thank you.
Thank you very much, Yasmin. And another thing going forward that we're all, I think, going to be able to engage with is how to support that linkage between health and between CVA in terms of how we coordinate and how we work together better. So that's something I think, whatever background we're coming from, that's definitely something where we can have an impact. So we've got 2 minutes left. We can take one more question if there's one, or else I could invite my panelists to say one last thing before we close. A quick goodbye message, or when you're thinking of health, do not forget.
I think it'd be nice to say from us that this is the first step, really. We saw what we did as an initial inquiry, but it showed up, it flagged up so many areas where more work could be done. And just flicking through the questions, which I haven't had time to look through in real detail, some really good questions such as, did we consult donors? And we didn't have time to talk to a lot to bilateral donors, for instance, but that would be a really useful thing. And more work around what are the right coordination mechanisms at country and regional level. Those were two areas which I feel we weren't able to really explore in as much detail as we would have liked. So perhaps they could be subjects of future work. And so thank you everybody for coming from Anna and I.
Thank you.
Thank you.
So I think we're going to leave it there and say thank you very much for attending, and thank you again to our panelists. Bye for now. Panelists can